Hey everybody, welcome back to another episode of Luna Unscripted, where we talk about real life, real career paths, clinical insights, and just share the nitty-gritty details of life as a physical therapist. I'm Katie Wiley, one of your hosts.
And I'm Joe Valdez.
And I'm Marcy Arenas.
Welcome back, everybody. I think Marcy and I just recently got back from some nice, relaxing vacations. How was your trip?
I hope yours was relaxing. Mine was not. You know, when you travel with children, it's much less relaxing than when you travel alone. Joe knows this, I'm sure. So it's much more
Oh
of
yeah.
a trip than a vacation.
Yeah.
But it was fine. The kids had fun, and that's what's mostly important. And
What
now
did you do
camps
in San
have begun.
Antonio? I don't even know what all there is to do there.
Funny enough, there's actually like Six Flags there. SeaWorld is there, all kinds of stuff. We went to Six Flags. I was less than impressed, but I've grew up in Virginia and we have Busch Gardens, which is a very nice amusement park. So I was spoiled. And then the place we were staying at had a lazy river with like part of it has like sandy beach area. I didn't need to plan anything. Like now that looking back on, I'm like, why did I plan to do other things? They could have spent all day just there. Going around the lazy river, playing in the sand. Going around the
That's
lazy river,
definitely
playing in
a
the
good
sand.
lesson. I'm like a planner myself, so I'm like, we should go and do this. We should go and do this. But yeah, you're
Same.
right.
And then I'm
Totally the
exhausted.
things the most time that is the most fun is when you just like enjoy where you are and hang out and relax. We were at the beach, so we were in the Outer Banks, and it was just wonderful. And we did try to
Oh,
embrace
nice.
that, just like enjoying the pool, enjoying the beach time, and it was really nice.
How was
Chaotic,
the
but
surf?
nice.
Because I know that there'd been like, at least in Florida, there was like red flag warnings about riptide and stuff like that. Was
It wasn't
there?
bad this time. When I went a couple of years ago, there was more red flags, but thankfully we picked a good week because Outer Banks can be a little bit extra windy and breezy around there. So no, it was good. It was nice. Well, my joints certainly got a little workout with climbing up the dunes because the dunes in the Outer Banks are definitely present. So just a great segue into our conversation today to talk about the knee. I know you guys are big fans of treating the knee, right?
Oh yeah.
Yep. Well, why don't you share where your love of the knee comes from? And then we'll get into more fun details about what we like to treat and our methods and all of that.
Yeah, well, I think that one of my clinics I was at was a big theater clinic for a lot of post-op knee patients. So I saw a ton of the total knee joint replacement patients, also a decent amount of like post ACL, post meniscal repairs slash meniscectomies as well. So I think just exposure to the knee just got me kind of feeling a lot more comfortable and enjoying it. And really, when you work any other part of the lower extremity, the ankle or the hip, the knee's always going to be involved. So there's always going to be treatments associated with that. So I guess it's more enjoyment by association for me, but it is a fun body part to treat.
I think
Yeah.
it's also more of, I mean, it's not a simple body part, but it definitely isn't like the hip that has so many movements and muscles attached to it, right? Mine, I have had knee pain since I was 9 or 10. Um, Through soccer, things like that. I went to PT when I was maybe 12 or 13. Didn't like the PT would tell me the exercises to do. I would do them while they looked and then they would walk away and I would stop doing them. So didn't get rid of any pain. And then I went to PT school, PT again while in PT school, and learned that I had patella alta and some other tracking issues. And so like that was kind of fascinating learning about yourself and then how to train that different exercises for the hips and stuff like that. And so I decreased my knee pain over time. And then similar experience with Joe. So I in pediatrics didn't see a lot of total knees, but we did do a lot of post ortho type ACLs. I did a lot of ACLs, MPFLs, patellar tracking issues, meniscectomies, meniscal repair, stuff like that. And so it's kind of fascinating the protocols for those. And I did research on ACL, return to sports stuff, and so really like the knee. I probably like the hip more now than I like the knee because the hip is more fascinating in all the things it does, but I really like the knee.
Do like the knee. Like I said, shoulders like my favorite. I appreciate the knee. I have also had knee challenges myself. I have what's called a discoid meniscus. Have you guys heard of that before? Where instead of
Mhm.
being C-shaped, it's D-shaped, so extra tissue. And mine has torn. Sometimes people are asymptomatic. They don't even know they have it. They just hear some clicking with that. So I had a episode of a few months of like really trying to avoid surgery, and then I ended up having to have surgery for it. So like love-hate relationship with the knee because of my own personal challenges that I've had with it. But it is one of the better parts to treat. I agree. I do love an ACL recovery. I think that's super like I used to be nervous about it when I first started out of school. I'm like, oh no, I'm gonna like screw this up for this kid, and like, until you get your bearings with everything. But then it became one of my favorite areas to treat just because you do see so much progress in a short amount of time. Do you guys love a total knee as well? I know, Joe, you were talking about that. I think that's when I have like, again, that love hate kind of when they go well, it can be so good and so rewarding, and you're really, getting everything back. But when you get a stiff knee, like it just, that's an uphill battle for sure.
Definitely. Yeah. I mean, it's kind of hit or miss with how people are going to respond to the total knee replacement. But like I said, I saw a ton of them at one of my clinics, and it's definitely a love-hate relationship. But I feel like you kind of learn some tips and tricks or kind of like how hard to push people that have maybe stiff versus, non-stiff knees. And I think early management of like education, also just like edema management and kind of pain techniques to kind of get them on board is super important. I know some people just try to yank on the knee early on, and that's just kind of no go, right? And kind of sets them up for failure down the road. But um, that's probably the widest range of like response I've seen to surgery though, is a total knee. It's just some are easy, some are, more difficult.
I agree. And
Yeah,
I think
I
it's
think
interesting how sometimes too, like people get their range of motion back almost too early. Like not too early, but like you're just like, let's not push it further than that because of that edema response, or because they're like, I've got the mobility, let me do all these things before their muscles are really like back and ready for it, and because they're still healing. So I think that's something I felt more confident in, just like holding people back a little bit early on when they're like a week out and they're already, getting close to 100 degrees. And you're like, okay, we're going to go slowly. You still have your incision healing, just being cautious on that side of things because I've seen it, be a challenge. What about you,
Absolutely.
Marcy?
Yeah, I would say probably like 75% of the total knees I've seen have been very meh. So, and then for a while I got like down on myself that it was related to me. And then I talked to, because I came from the pediatrics world, so we don't see those. So then I talked to some other clinicians and they were like, well, what did the patient look like before surgery? What kind of range of motion did they have? And so that dictates a lot of what they're going to look like afterwards. And so even if I had a patient that had decent range of motion, eventually they all had pain. Pain, 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 pain. And they'd have pain down the tibia or down the fibula or somewhere. And it was predominantly what they would talk about for weeks after. So I think comparatively to the hip that I have found heals a little faster, maybe. The knee is not I see a knee and I'm like, great. I mean, I'd rather treat that than a back for sure, but great.
Yeah, no, I agree. I think the knees can be painful for a while, and I feel like sometimes they're given the expectation like you're going to be pain free afterward, where like
Yep.
it's probably going to be better again. You're not going to have bone on bone or some, those locking and mechanical episodes with it, but will it be like 100% like your non-arthritic knee? Maybe not. I feel like just managing expectations with it is important. On that note, how do you guys feel about like prehab, like before ACL, before total knee, before some of those big surgeries? Is that something you've seen a lot of or seen success with?
Absolutely. I mean, I think any sort of like building up of muscle before the surgery, like kind of provides confidence for the patient because they already know kind of what to expect afterwards. And it kind of prepares them for, they're not starting off as bad, I guess, weakness wise after the surgery. But, I've seen some good results with it.
Yeah, huge prehab person. I started a prehab program at Shriners when I was there to get all of the patients in beforehand. And even if it wasn't, weeks at a time, even if you could give them some expectations and some education and a little bit of range of motion and strengthening, yeah, I found pretty big differences pre-op and post-op. We're bound by PTs for reimbursement insurance coverage. Shriners is nice because they're not bound to that. So I found in treating clinically, it's harder to do prehab. But I think that long term, if there was investment in prehab, you'd have less post-op poor outcomes that require things like MUAs or potentially surgical revisions, things like that.
Yeah, I agree.
MUAs, hate those.
Hate them.
I
I've had a few
know.
patients that have hated them.
Yeah,
Terrible.
same. Yeah, it's never fun when that needs to happen. Then you have like 5 days of therapy straight after. Oh, it's a lot. How long was your prehab like program? Was it like a couple of visits or what was like the protocol for it?
I mean, the goal would be because for a lot of these kids, they're ACL tears. And so it was to decrease, they wouldn't operate till they could decrease the swelling and some things like that. So it wasn't a significant amount of time. But it was usually my goal would be about 2 to 3 weeks. With Shriners, you also have the insurance piece isn't an issue. Most of the time, they are lower socioeconomic patients, and so the transportation piece became a harder thing. So trying to get them in more than one time a week was challenging. Um, but trying to getting them in, my goal would be 2 times a week for 3 weeks before surgery, and then we start them literally like 2 days after surgery. And we had a pool, and so once they were cleared to go in the pool, we could do earlier, higher level training in the pool before we could do it on land, stuff like that. So that part was like ideal. It doesn't happen in the real world, I know, but CPMs that I want to hear about your guys' with CPMs. I personally am not a fan of the CPM. I think it is bulky, annoying. There's not much research with it. But I will say, after I had a patient with an MUA, the CPM was like the only thing that would get her the range.
I like in the fact that obviously it gets things moving. Um, Similar to what we were talking about with the shoulder and like posture stuff, like the passive versus like being able to kind of control your own positioning and destiny. I like the idea of the patient taking more onus of moving their joint versus something externally doing it for them. That being said, I'm like such a huge supporter of like the rocking on the bike, like having a recumbent bike or even encouraging them to have like a stationary pedaler at home and like kind of getting it moving on that. So I guess that's semi-passive, but again, they're controlling it and being able to do it. And I feel like that just helps with their outcomes and their ability to just manage things better. I feel like sometimes when they rely too much on the CPM, then when it's taken away, they're like, well, what do I do? I don't have that anymore. So that's just my 2 cents on it. But I agree. I haven't seen super consistent research one way or another, just more one doctor's preference versus another.
Exactly, right. It's usually surgical or surgeon preference in terms of assigning a CPM to a patient, and same with both of you. I just haven't seen a whole lot of good results from it. I'm sure there's some patients that really benefit from it, but I feel like setup, I mean, they're doing it on their own. Half the time they just don't have it set up the right way to begin with. And so they're not really doing it or using it how it should be used. And so that's one thing. And then two, like Katie said, they don't really have as much control. And I'd rather them kind of like she said, get on a stationary bike or get one of those little pedalers that they can stick on the ground and or under their desk and just kind of rock back and forth. I'd rather them do that than get hooked up to a CPM.
Well, I will say, so we talked about some of the diagnoses we do like. One that I have not been a super big fan of, and I like yourself, was in an outpatient practice, saw a lot of post-op knees. I don't love a meniscus repair. I feel like those can be particularly challenging, and it may just be the cohort that I got for a period of time that seemed to be people who were like putting off total knee replacements. They were like, all right, let's give you options. They'd had multiple scopes. And, I had so many that were like these 50-ish-year-old women, and they would get these meniscus repairs and be non-weight bearing, which for these specific patients I had was so difficult. And then their other leg, their other knee and hip would start bothering them because they're basically jumping around on it when they probably didn't have a ton of cushion over there anyway. So that I feel like that's just one of those things. I'm like, why did we make that choice for that plan of care for that patient? Like I can think multiple in my head right now that I'm like, why? I don't know. That's just me though. That's my specific situation. For the younger clientele, that might be different, but I had an influx of those type of patients at one point that I'm like, why are we doing meniscus repairs on this? I don't know. Have you guys seen that too?
Yeah, I mean, meniscectomy is piece of cake. People would be out of
For
the
sure.
clinic or like out of PT within a few weeks, but meniscus repairs, I think the weight bearing aspect was the toughest part because, like you said, they would compensate by hopping around and then they'd have other issues, or they just wouldn't follow the precautions and have so much pain and complications. And so I agree with you. I'm not a fan of meniscus repairs. If you can get them past that initial phase of non-weight bearing, though, usually I think things go much better after that.
I haven't actually seen a meniscal repair in an adult.
Oh,
A
okay.
lot in PD, and in PD it's not as bad. So yes, there is the non-weight bearing aspect of it, so that kind of delays some of the functional retraining and neuro rehab stuff. But I never really had a. I didn't love when ACL was combined with meniscal repair because that would just delay everything. My least favorite thing at the knee is the Baker cyst.
Yeah.
Dislike everything in the back of the when they're like, I feel a bump back here. I'm like, "Ooh," all that stuff. And then we actually did a bunch of lengthenings. So we did femoral and tibial lengthenings.
Oh, interesting.
And so we used an IM nail, was magnetized, and they would stick that in the femur, and you would put a little like magnet over top of it. It would lengthen, it would rotate and lengthen the rod a couple millimeters every day. And the surgeons wanted PT every day because one of the big risks of it is patellar dislocation, but you can't do anything other than range of motion when it's actually lengthening. And so I'm like, this patient doesn't need therapy every single day. It's not uh, clinically necessary. And so you were constantly fighting with the surgeon of what, like they monitoring stuff like that. And then you could only do so many exercises until they were done lengthening. If it was a tibial lengthening, up until I think in the last year they've started doing the IM nail. But before they were using external fixators, and so that comes with all kinds of pin site control and stuff like that. So
Well, it's nice you didn't have visit restrictions. When I think of like PT every day, I'm like, how many insurance visits do they have? Same with like prehab too. You always have to be like, well, they could use, 6 visits before surgery, but if they only have 20 visits per year and it's this lengthy recovery, like it just gets, kind of difficult in juggling that side of things compared to, just being able to do what is medically indicated.
Yeah, I mean, I saw a couple, but I mean, the couple that I saw were like, we just kind of dealt around it, they just existed for the patient. So we didn't really treat them. Usually it's like something else is going on and then they happen to have a Baker cyst and we just kind of left it alone and did what we had to do for what they were actually there for. So I guess I'm curious because I didn't really see a lot of it, but is there anything specific that you don't do for a Baker cyst, Marcy?
so in like the clinic for like the 2 patients I've seen with Baker cysts, it we did a lot of like manual stuff on the back to try and I think a lot of it also the hamstrings were because they were in pain, the hamstrings then overcompensated. So they had tight distal like hamstrings, especially the medial side. And then I feel like IT band was tight a lot. So a lot of manual work, but now with ChatGPT, you'd probably be able to figure out better exercises for a Baker cyst. But when I was in the clinic and didn't have ChatGPT before it existed, I know. I was like, I don't know what to do for this. I'm just gonna pretend to rub back here and can never go wrong with some glute med exercises and did some random stuff. So I think maybe it was also my lack of familiarity with it and kind of what to do versus you give me an ACL and I could in my sleep progress them. So maybe it was part of that.
Almost can be so painful. And
So
then
that sounds
they're
about what I did.
avoiding terminal knee extension with it too. So like it just throws off the mechanics so much. So I agree. I've not seen them independently for Baker cyst, but like in conjunction with other things, like they had knee OA or they had some other injury too. What's the most interesting way you guys have seen someone injure their knee? One that always sticks with me as a parent is a parent like jumping at a trampoline park with their kids who like tore their ACL. I've seen more than one of those, and I'm always like, I'm gonna like be here and cheer you guys on, but I'm just, especially with my knees how they are, I'm like, I'm gonna stay over here and I'm gonna like yay, and not actually jump on these trampolines with them.
I had a cop one time who he saw a lot of action in his job, and one day he wasn't even on a chase or anything. He just stepped off the curb awkwardly and tore his ACL. And his whole first visit, he's like, dude, I just got in a fist fight the other day. I went on a high speed chase. My knee's doing great. And then I happened to just step off the curb and my ACL tore. He's like, what the heck? And so I felt a little bad for him, but he was actually a really positive guy, and we got him back pretty well for his job. But yeah, that was probably the most ironic way I've seen someone tear their
Maybe
ACL.
the straw that broke the camel's back, right? Maybe he
Yeah, I
had some
guess.
like spray or stress on it, like leading up to that, and then
Yeah,
What
you
about
wonder
you?
how some people can do all these twisting motions, or it would look like they hyperextend. You're like, they tore their ACL and they didn't. And then someone steps off a curb and tears their ACL. I mean, is it like genetic component? Was it already partially torn? That type of thing. I had a teenager who was not an athlete, but was playing piano and got up from the bench of the piano and tore hers. And I've also had a 9-year-old literally walking the track for PE tear his. So like you do kind
Just
of think,
walking,
and
like,
ACL
didn't
tears,
fall or anything, just walking.
yeah.
Wow, man, go figure.
Yeah, and tears in kids younger than 10 or 11 are pretty rare because, yeah, they're very elastic, you know?
Right.
So that also kind of makes you th and his dad had previously had an ACL tear. He actually never had it fixed. So he was like not using his ACL. So that does kind of like, is there a genetic component to kind of how stiff the ACL is or like what the tendon part is made out of, the ligament?
Yeah, I mean, I would assume so. I need to do some more research and CEUs on that, Marcy, because that is interesting. I've met people without ACLs. Have y'all met people without ACLs? That's
Like
always
they
kind of
tore
interesting.
it and they've like just rehabilitated, or I am not aware of this. Is there people who are born without these things?
Yeah, that's a good question. I mean, they would come in and say they didn't well, they didn't have a functioning ACL, so maybe they tore and just decided not to go about it. I
Right.
think I might be making this up. I'm pretty sure I've met someone that didn't have an ACL, but it's just so interesting. You do the test and it's like super lax, right? When you do the anterior drawer test and Lockman's and everything, but then they live with it, and it's just
Treated
kind of
like three
interesting.
or four non-op ACL tears, and as long as you're not getting back to like running and they're not like super hyper mobile individuals, I feel like it came out pretty well. Like honestly, it was, yeah, not too bad. You would think it would be more restricting and limiting, like you get over that initial super inflammatory phase of things. But yeah, they did fine with it. It was just, their choice, and they weren't going to be getting back to athletics. So it worked out. But yeah, I'd be curious. I'll have to
Yeah.
look it up to see if anybody was born without one. But I bet it was just
Yeah,
somebody
I
I
who
think
feel like I'm
tore
making
it.
this up now.
No,
I
no,
gotta
no. I
look
think it's true. I don't think it's a high percentage of people, but I have heard of someone who was born without an ACL. Now, I do recall from like the surgeon I talked to that it's rare and that the PCL will have some fibers that'll act more like the ACL, but it will feel loose if you do an anterior drawer or Lockman's. But I have seen adults without doing ACL repairs, and they're fine. I mean, even when I've had patients who have torn their ACL and they come for prehab, I tell them you can still do racked squats. Like you can do weighted exercises at the gym. The only thing you can't do before surgery or without is any type of twisting, quick motions, agility stuff like that. But you can definitely still go to the gym and do like a full body workout, strength training without an ACL. As a PD therapist, I recommend pretty much every patient to get a repair because I was like, even though you're not an athlete now, if you want the ability to be able to do athletic type of moves when you're older, you're going to want it repaired versus not have it. Um,
Well, and the risk
but
of
taking what I
arthritic
saw,
changes too long term when you're living without a functioning ACL, just that shearing force and the risk of higher, arthritic changes. I mean, when you tear alone, you get that, but then if you don't have it repaired, then setting the more risk to that then too.
exactly. Yeah, that and seeing that like the course of their recovery and how long it really is till you're getting back to the things you want to do, that kind of led me to when I went to adults, the same thing, being kind of like not recommending an ACL repair if they were like, I just like to walk the mall or something like that because of I'm like, it's surgery. So you're still at risk for all kinds of different other comorbidities and issues after surgery, plus a stiff knee and not fully getting the extension back and the weakness piece of, I was like, anytime you touch anywhere around the knee with surgery, the quad just completely inhibits. And so all of that. So older people, not as much, but I love me an ACL repair. It's my favorite thing.
Speaking of quads, so I love myself just intervention wise, like a standing TKE. That's one of my favorite exercises, like with a band or with a ball against the wall. I feel like compared to like laying down, people just like get it more, and you can like
Mhm.
cue them a lot on like avoiding the hip compensation. That's one of my favorites. From a tool standpoint, have you guys used those threshold activated NMES stimulators? So where they have to like contract to a certain point and then the stim will kick in. That's one of my favorite post-op tools. I can't for the life of me remember what the specific brand was called. I think there's more than one, but where like they have to like contract to a certain point and then it'll kick in. I love that one. So good.
I don't think I've seen that, or I've never used that, by the way, but I think that's a great concept, right? Make them work for the assistants.
Exactly. And then they
Uh,
get the feel of it too. So they like they know if they're kind of contract properly. And you as the PT can obviously adjust the thresholds at which it kicks in too. But yeah, that was one I always really liked a lot. What are your guys' go-to like exercises? I know we already talked about glute med stuff. I love a good like sideline hip abduction versus like clamshells. I feel like clamshells are often
Yeah.
improperly done and not necessarily targeting what we would like with it. So I'm like, there are times it's appropriate, but I prefer the hip abduction sideline. But yeah, what do you guys like to do?
I love using the TRX, especially, getting people back into like squatting. I'm a big, weight bearing and squats, lunges type of PT. And so when they're early on, using the TRX to kind of offset and make that squat a little bit easier, and then progressing that to maybe like a single leg squat, was a big tool that I use in the clinic. That and also like leg presses, right? So any machine that they could do a leg press on, and I use it for, both, the double leg press, single leg press, but also introducing plyometrics as well, because then they could like push off, on the leg press and like adjust the weight for how much weight they're like jumping off their feet. So those are probably the two
I do
biggest
that
tools that I would
too with
use
the
with.
shuttle press. Is that the one you're talking about?
Yeah,
The
the
one that has like
shuttle.
the bands? Yeah. Oh, I love it. Yeah.
Exactly. Yeah.
Yeah, we didn't have all that fancy because at pediatrics you don't get fancy equipment. I mean, you don't get fancy like workout equipment. We had a locomotor training system for strokes, and we had a balance thing. But for ortho sports, yeah, it wasn't as fancy. Um, the more research I did into ACL stuff, the more I was like, as soon as we get that quad firing, up we go, standing. And so a lot earlier than I would say most people would get up and moving around. I was like, let's get some functional exercises in, feel that weight bearing to get to the brain. So I would do a lot of wall falls, single leg, double leg, side to side. We would do like single leg steps where you would stand on one leg, take a big step to your other leg, and then we would do zigzags of that forwards and backwards. Where you have a slider under one leg and you're doing different types of slides with that. And even starting plyometrics pretty early to do some return to run and return to sport activity. Agility ladder, 6 weeks in, agility ladder, you're not running through the agility ladder, but trying to get different movements in the agility ladder to get some symmetry.
I like it. Yeah, I like especially with the gait training too, with like stepping onto the uninvolved leg. I feel like that's something that takes so long for so many people to get back properly, is that like their terminal stance with that involved side. Like there's so much of that compensation, and then they end up with back pain and hip pain and everything because they don't get that down. So I think working on that early is really good idea.
And that's where having a good relationship with a surgeon is helpful because I've had so many surgeons who are like, you could just drop the crutches whenever you want. And then I have to be the bad guy that's like, actually, we really want to keep those until your gait pattern is more normal because otherwise you're going to be stuck in that pattern. And so trying to finding eventually like the groove with a surgeon who's like, your PT is going to handle all of that. They'll tell you when to stop using the crutches and all that kind of stuff. So I also think it's surgeon dependent, but yes, when given the right opportunity, I've had patients seamlessly come off two crutches to one crutch, that type of thing, down to nothing. And then I've had ones that I'm like, no, 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 you need to go back to the crutches.
Have you guys had any good continuing education courses that you've taken for the knee that you really love?
The one I
I
mentioned last time about the shoulder, that Kevin Wilkes one, that was a dual like knee and shoulder one. So that was definitely a very good course. I'd recommend that for sure. But what about you guys?
Uh, Chris Powell, I think that's his name. He's out of California. He does a bunch of sports stuff, and so he has a good knee course. I took a sports metric certification up in Cincinnati. Hey, Cincinnati, it's close to you. And so they do some good knee stuff. Other than that, I I think looking for me, a big thing for ACL is the return to sports, like the battery of tests. When I have kind of PRN'd at different clinics and I see ACL patients and I look at their goals are like that they can squat 10 times, that they score whatever on the lower Show Me functional scale, and that they can run so far. But no one's looking at limb symmetry index, or the gold standard for ACL is the ACL RSI, and no one's looking at the hop tests or
Well, we
strength
always did
compared to side to
FMS tests
side.
too. Do you guys do that one? The FMS testing, functional movement screen? That was always a big one.
I've done that. I've done that in general. I've actually used that when I was with one clinic. I would go to different soccer teams and I would use that as a screen to kind of determine who was at risk of an ACL tear and then give the coach ideas of things to work on. I didn't use it post-op ACL. I would use like a battery, like the hop test battery, the agility T test, or the 5-10-5, and then the where you drop down and you jump up, a couple other tests. But I use the
You
FMS
guys
as like a
got
screening tool.
isokinetic testing too. That was one we always did with our ACLs before return to sport, and just to kind of see where we were. And sometimes, they look pretty good, and then you get on that and you're like, oh no, we're not, we're not quite there yet, but we'll keep working for it. But the
When
FMS,
do
I do like that for a post-surgical, like pre-return to sport screen too.
I was lucky we had a motion analysis lab. And so when we eventually did research on our ACL return to sports, once I tested them, we would send them to the motion lab to do similar tests, but they would have, all those little dots on their body so you could look at the levers and all that kinds of stuff. And so that really gave you detail on, okay, as the PTI, I can see this, but the machines can pick up this. And so kind of fine tuning the different testing. So we were kind of spoiled. And obviously I could see patients until 9 months, 12 months post-op, which was a big, like, you're in the real world change when I went to ACL repairs in clinics where they're like, you have 6 visits. And I was like, excuse me, what?
No, I think it was interesting too. I feel like early on in my career, there was a push for getting people back to sport post ACL around like the 9 month mark. And then they were seeing all of these like re-tear influx. And then they're like, all right, we're going to push it to like 12 plus now, which I'm like, it can be a challenge insurance wise to like follow them through that length of time. But I mean, you can arm them with what you can. And yeah, I think that's definitely the better choice with it. Well, any other diagnoses you guys want to hit on? Any other treatments that you like a lot, or diagnoses that you like to treat a lot?
I think we nailed them all. One thing I do want to mention about like testing as well is the dynamometer. Something I didn't really use early on, but I feel like that's just a simple, easy way to determine like how strong they really are in that injured leg compared to their strong leg. And being able to kind of assess like when they're ready for the next, phase of treatment. And so that's something I've been trying to incorporate a little bit more is the dynamometer
Do you
with
have one?
Interesting. I've never really used
you
that
can
with.
use well, you can actually makeshift it by getting those little, they're like things that weigh your luggage. I think what
Oh
they're called, like a crane
yeah,
scale.
that makes
Yeah,
sense.
if you can makeshift it with that, and then you just like tie a rope around it, and then they push through it, and you can read it. It's pretty accurate. So, that's kind of yeah, that's kind of my go-to. But I have had clinics that have actual like dynamometers that are, I guess, more. They're so expensive, like several $100 for like a good one. So you can buy a crane scale for like 40-50 bucks on Amazon. It does the same thing.
Weigh your luggage, push against it, same thing. I like
Yeah.
that better than you remember those giant machines they would like a lot of surgeons had to do ACL recovery where you had to be in this machine, you would push it so many times. I forgot the name of it. The dynamometer I feel like's
Oh.
better.
Yeah, yeah. I can't remember, but I know what you're talking about.
Yeah.
All right. Wow. Okay. I have a couple of good knee jokes for you here today, so prepare yourself. Okay, let's see which ones I want to go with. Okay, knock knock.
Who's there?
Alpaca.
Alpaca who?
Alpaca who?
Alpaca an ice pack. You know you're gonna need it after today.
That
Great.
could go for any body part, right?
I know, but especially I feel like these, especially like you're gonna need one after today. Okay, got one more. Let's do. I have trust issues with my knees. They're always giving out on me. Yeah. Okay, I'm done. I know. Corny. But all right, well, thanks for joining us for another episode of Luna Unscripted. If you have any favorite things about the knee, any good interventions you like to use, let us know. Feel free to comment below and follow us to hear more and hear about our next episodes.
Bye, everyone. Thank you for listening to Luna Unscripted.